Welcome, everybody. I'm Mary Ann Udow Phillips. I'm the director of the Center for Healthcare Research and Transformation. We are hosting this summit, and we are simply thrilled to see all of you here on this unbelievably gorgeous day in the middle of July in Michigan. We're so excited that you are willing to spend the day with us thinking about how we can really fundamentally improve health and healthcare in our state. And your participation today is really a testament to the commitment that each of you have to that mission. So this is going to be a little bit of a different kind of session than I think most of us are used to. This is not just a session about learning about some things, feeling enriched, and going back to our offices feeling energized about our jobs. We are hoping that that happens, but we're also hoping that by the end of today, we actually have teams formed who are willing to work together across sectors and across the state on problems of common interest. And we've identified, the planning group has identified 6 possible themes. You're going to hear about those a little bit later. This is not meant to be exhaustive. There could be others. These are just the themes that the planning group came up with that we thought were very amenable to the concept of the learning health system, the learning health state, and you're going to hear what that means in a minute. But don't think that this is exclusive. We'll ask you if you've got some other ideas later, and you'll hear about what these themes look like when the panel presents in a little bit. So I want to do just a couple of things. I'm going to introduce the panel a little bit later. All of the panel members were on the planning group, but we have a few members in the audience who were also on the planning group that are not on the panel, and I want to introduce them and ask them to stand so you know who they are. They are Josh Rubin and Tim Pletcher. And I think Dennis Smith is not here, right? And, oh, Dennis is here, right back there. Right, Dennis, that's great, from the UP. And then we have a couple members who are not here. Andrew Rosenberg and Patrick O'Hare could not be with us today. And I just really want to thank the planning group, those who just stood, and those who are on the panel for all the hard work to get us to the summit. And many of them, almost all of them, maybe all of them, have volunteered to help us carry this mission forward. So it's really been a great commitment by all of them. I also want to welcome and introduce Hunt Blair. You want to stand for a minute? Hunt is at the Office of National Coordinator at HHS, and they have just added as part of their 10-year plan to really help move the country to a learning health system, and that is really a great addition in the ONC 10-year plan. And as we were chatting before, we think Michigan can be leading the way, and that's really what we want to see if we can accomplish, at least start that process by the end of today. So I don't want to take too much time in the introduction. We are going to ask you this afternoon. This morning is all about learning a little bit, getting some background, understanding what we're talking about when we talk about the learning health state, what it could do, how we could do it, and then hearing about these themes that the planning group has identified. The afternoon is all about working together. We're going to ask you, and we've asked people to sign up for a theme, and you can do that at the breaks. Again, you'll hear a little bit more about what those themes look like from the panelists here. And we're going to ask you to work, and we'll tell you where you go to do that as a group on really fleshing out that grid that we sent you that was not meant to be the be-all, end-all. It was a working draft. We're going to ask you to flesh that out, make it more realistic, and determine whether or not we've got a theme that wants to carry forward after the summit, and we've got a group of people who want to, cross sectors, work on that theme. This group here, you represent just about every stakeholder in healthcare. You represent consumers, you represent coalitions, you represent providers, health plans, the state, you represent those who've been working in information technology, you represent those who've been working in advocacy. And it is just an amazing cross-section, and together we think we can make the kind of advance that we need to really move health and healthcare in the state. It would not be a conference that has people who are really techie if we were not tweeting. And so we are tweeting this morning's plenary session, and if any of you want to tweet, you can do that. It is hashtag what is it? LH4MI. LH4MI. And you can tweet that, and you may see some tweets going out from others. So that's my introduction, and I'm going to now introduce Tom Simmer and Chuck Friedman to start with, so that they are going to take us through these introductory discussions about what a learning health state is. Their bios are actually in your materials. I don't want to spend too much time on their bios, but I do want to give you just a little bit of a flavor for each of them. So Tom is going to start. I know many people in this audience know Tom. I've had the pleasure, really the privilege, to work with Tom for many, many years. And for those of us who know Tom, we know what a leader and a visionary he is in healthcare. He's the Chief Medical Officer at Blue Cross and Blue Shield of Michigan, where he has launched major initiatives like the Physician Group Incentive Program, like the Michigan Quality Improvement Consortium. He has spent his whole career dedicated to improving quality of healthcare and the efficiency and affordability of healthcare. So we're delighted that he's going to kick off the discussion about what a learning health state could look like. And then he will be followed by Chuck Friedman. Many of you who work or have spent any time in the health IT space know Chuck well. We heard earlier, in fact, some people even teach about Chuck in their courses because of his long and illustrious career in health IT. He was at the Office of National Coordinator, launching the meaningful use initiatives that many people are now working with today. He is currently at the University of Michigan. He is a professor in the School of Information, in the School of Public Health, and the chair designate in the Medical School for Health Informatics, Medical Informatics, whatever. Learning Health Sciences, there you go. And a member of the Institute for Health Policy and Innovation at the University of Michigan. He, too, has dedicated his career to advancing quality, efficiency, and the effectiveness of the healthcare system, and to use information and data in a way that actually improves health and healthcare, as opposed to using it for an end in and of itself. And he's also going to give you that framework of what the learning health system is all about. So with that introduction, I'm going to turn it over to Tom, and then we'll hear from Chuck.
Thank you. It's really exciting to be here on this sort of inaugural event where we really want to transform our organizations, and so many of us are in the business of transforming our organizations, and that's really, really hard work. And we hope that the consequence of today's session is that everyone in this room will have a clearer insight as to how to proceed with what you do every day in a way that's far more effective for you, because you are collaborating more effectively with others that allow you to get on the learning curve that you need to be on to succeed in what you're doing. I'm going to show a few pictures of things where the people who created a certain product or reality didn't start off knowing what they were going to create in the end, but went through an exciting learning process that continues and continues, and that learning process results in amazing things happening. So I use this slide because this is a contrast of two types of farming that's happening in the world today. We have one group of people using sort of a back-breaking approach, really, it's quite obvious, and they're proceeding in the way they were taught, as opposed to proceeding according to what they have learned. At the same time, you have others where you can't use the equipment from a few years ago because there have been so many improvements and advances that you can't do your job as effectively unless you take advantage of the learning that's occurred. And I think this is kind of where we are in healthcare right now. There's so much of what we do that's cutting edge, that's the best science, that wasn't even dreamed of a few years ago. And side by side with that, we have people who say, when I was taught, this is how we do it. And that's how they live, as opposed to saying, we're going to proceed because this is what we have learned. And it's kind of amazing how you can be stuck in the same pattern forever if you simply go with what you've learned or with what you were taught as opposed to what you are continuously learning. So here in aviation, I think these are two good examples. On the left, you have the Ford Tri-Motor. And you know, Ford Motor Company was one of the early leaders in the production of airplanes. And the question is, why didn't they stay there? And the answer was, their learning curve was in production. The technology learning curve that was needed to create the next generation of commercial aircraft was too quick of a learning curve for Ford Motor Company to keep up with. That wasn't their learning curve. Their learning curve was the production line. So instead, the business of creating commercial aircraft for passenger flight has switched to other companies. And the Dreamliner on the right has been a very storied airline with a learning curve that is sort of up and down, but Boeing really tried to take commercial aircraft onto a different level and have gone through a very strong learning process, which has had really some bumps along the way and difficulties. And I think that all of us are going to experience the same. But you can't create a Dreamliner simply with what you were taught. You've got to go into areas where you continue to learn. Here I like this because this is the horseless carriage and the driverless car. And both of these products are the result of people saying we're not going to take what we already know and just always do it that way. We're going to keep learning how to do things better. And it was kind of interesting here because even the Ford Motor Company, which was obviously the world's most incredible innovator when it came to automobiles, got really enamored with the Model T that you see here and created 15 million of them before they realized that they have to not just innovate on production to produce the most cost-effective vehicle on the roads, they really have to keep up with modernizing the product. And that was a difficult lesson for Henry Ford to learn. And in fact, it took a lot of people to help him make that transition. With Google, of course, they're not even in the car industry, but they have an idea that industry can be transformed, and they're simply getting on a learning curve to see if driverless vehicles can be practical. I read somewhere that the only way they're going to be practical is when they're all driverless. And I thought, how do you make that transition? Well, that's sort of the transition challenge I think that all of us have in our organizations today. I want to contrast this because this is a picture of a physical exam for a patient from the 19th century and a picture of a physical exam recently. And this is what I consider to be sort of the archetypal example of this is how we were taught. And so this is how we do it. I have an excellent primary care physician, a graduate of Harvard Medical School, and I have the most traditional experience. I love history, and so my own physical exam is like a journey into the past. It's amazing. Every year for 10 years, I do the turn your head and cough to make sure I don't have a hernia. And that is such an incredible example of doing something the way that we learned to do it years ago and then not changing how we do it over time by learning. And there's a lot of reasons why we don't change. In this particular case, you must be true to the CPT description of the service if you're going to bill it. So the CPT description becomes a straitjacket, and we stop learning. We start complying rather than learning. And what we're really finding, and this is one of the themes that we'll have, is how do we improve this service so that we can get back on the learning curve and start doing a better job, because the core of having a productive interaction between the caregiver and the patient is learning how to have a productive interaction. And with all of the different electronic media that are out there, and with all of the evolving understanding of what we need to accomplish in healthcare from a population health perspective, we realize that we'd better get on that learning curve because this isn't going to be working for us in the future. So I wanted to end with this quote, and I'm going to see if I can actually try to read it because I think it's so important. This is an unsolicited comment from a physician at Spectrum Health related to the excitement and the importance of the learning experience that this physician participated in because of the collaborative quality improvement efforts that occur in joint replacement across the state. So all these competing organizations discovered that it's a whole lot better to get on the learning curve together than to be in silos doing it the way you were taught and failing to improve. So as physicians in healthcare institutions, we are long overdue for reporting and tracking our clinical outcomes. We have been operating in a black box too long. And that black box means you're lacking in a feedback mechanism that allows you to learn. The collaboration of member institutions within the Marquee Consortium has been invaluable to facilitate process improvement at our member institution, Spectrum Health. As the 6th largest provider of hip and knee replacements by volume in the country, and top 2 in both hip and knee replacements in Michigan, we have seen dramatic improvements in our quality initiatives as a result of having access to outcome data. Being able to benchmark our results against our peers and, more importantly, collaborate to identify best practices has raised the bar for our institution as well as individual physicians and ultimately should have a positive impact on patient safety. I think this is incredible because what you're talking to here is a leader in the field, one of the top ones in the country, and what's the message? We had so much to learn through collaboration. So he concludes with, we are grateful to the Marquee Project for improving our institution and our physicians and giving us this opportunity to improve. So I hope that that's what we do today, is create for all of you a mechanism for you to do what you're good at and do it better, and to do it through a process of collaboration and learning.
So thank you very much. This meeting is a dream come true for me. I'm just so delighted to be here and to see you all here and to have the opportunity to build a bit on Tom's remarks, being perhaps a bit more specific about how a learning health system, and in our case, a learning health state, can be realized. I want to emphasize something that Mary Ann said, or maybe it was something Tom said, but one of the two of you said this, that we have a sense of where we might be headed. We are going to have to invent a way to get there. There is no formula, no equation, no blazed trail to becoming a learning health state. This is an adventure on which we are all embarking together. I also want to, before I get into the details of my slides, say something about this word learning. And you just heard from Tom several examples of the importance of learning and the significance of the concept and the approach that rallying around the term learning brings us to. Mary Ann mentioned that if the Regents of the University of Michigan approve this in the next 6 days, I will become the chair of a medical school department called the Department of Learning Health Sciences. This reflects an investment by the university and the medical school in this concept of learning, and this is yet another example of a movement which is taking hold not only in Michigan but across the country, and in fact around the world, to make our health systems into learning health systems. And now I will say a few words about what that means and perhaps suggest some steps that we might take that are reflected in the structure of this meeting to get there. So it follows from what Tom is saying and his example of his annual physical that it's probably safe to say that our current health system is a non-learning system. And I believe it has 5 features that might convince us that we don't have the learning health system that I think when we think about it, we would all like to have. Instead of being available for study, which creates the potential for learning, pretty much, although there are exceptions to this and there are important exceptions, data from patients' experience, whether they reside on paper or whether they are in digital form, pretty much reside in silos. It is very, very hard to put data, to assemble data from different places so we can study and learn. It's been widely established that knowledge that results from studies of various sorts, because it resides pretty much in journals, languishes for as much as 17 years before it reaches widespread implementation in clinical practice. Our studies, our research that we do exists in almost a separate culture from practice. We're either practicing or studying. And many people believe, including myself, that to realize a learning system, to have a system that learns, those two cultures have to come together. So we're studying as we practice, and we're practicing as we study. And the studies we do, because we have no infrastructure to support them, or not a mature infrastructure to support them, are very, very cumbersome and cost prohibitive. I've just seen statistics lately that suggest that the cost of doing a clinical trial in the US has now reached $50,000 per patient whose data are reported. That is simply unsustainable. And last, but certainly not least, instead of the kind of safety culture that is most prominently seen in aviation, and Tom referred to the culture of aviation in his talk, a safety culture values continuous improvement. And instead of having a safety culture, unfortunately, we appear to have more of a blame culture. And in a blame culture, we hide adverse events rather than reporting them. And unless we report adverse events, we don't have a basis for learning, because you have to have a full account of what actually happened, both what went well and what went poorly, in order to learn. You have to be able to associate good outcomes with what happened to cause them, as well as associating bad outcomes with what happened to cause them. Another example, and this kind of brings us a little closer to the concept of the learning health system, we have no way to study ourselves in anything like real time, and we can't detect safety signals. And the graph you see here can only be made in retrospect. This is a graph that was constructed in retrospect. It has accurate data in it, but this couldn't be constructed as the events depicted here were happening, and this is a graph of myocardial infarction incidence as a function of time. And I think you could stare at this chart, this diagram, for about 5 milliseconds and conclude that something happened in 1999. And what happened in 1999 was the introduction of Vioxx, the COX-2 inhibitors, on the market. Does anybody know when Vioxx was taken off the market? The next year? The year after that? 2004, I believe. Many advocates of learning systems believe that with the ability to monitor and the performance of our health system and create diagrams like this, figures like this in real time, Vioxx probably would have been taken off the market in 6 months with attendant savings in lives and suffering. So the Institute of Medicine deserves credit for inventing the concept of the learning health system, and they have in fact produced a whole series of books on the topic. They call it the Learning Health System Series, a very original name and here are two books that I would just point out to you. One that goes a lot to what we're going to be talking about today, which is the more geeky publication called The Digital Infrastructure for the Learning Health System, which resulted from a study sponsored by the ONC when I was there, and a more recent study which goes more to the policy and care implications of having a learning health system called Best Care at Lower Cost. I recommend both of these volumes to you, and all of these slides are in your handout package. Calls for the learning health system are coming from a wide range of places and a wide range of authors. An editorial written by Arnold Milstein that appeared last year cited the learning health system as one of 3 essential steps that is necessary to reduce safely healthcare's gross domestic product footprint in this country. So a health system that can learn is the opposite. The same 5 points appear on this slide from the somewhat unsatisfying example that I gave you before. In a health system that can learn, every patient's experience is available for study. Best practice knowledge, instead of sitting in journals and languishing for 17 years, is immediately available to support decisions, not only by providers, but by managers and administrators of care, and also for patients themselves. Study and practice are merged, so improvement is continuous. This learning curve that Tom talked about is empowered and fueled by this merger of practice and study. Probably most important in terms of what we have to do is this happens routinely and inexpensively and almost invisibly. And I'm going to come back to this word routine, because a learning health system is one that efficiently supports continuous study and improvement. And in a very, very mature learning health system, this has become such a routine part of the environment that it almost disappears. It's just the way we do things here. And you have to think about it in order to realize it's going on, because it's become so routine, like so many things in life that become routine. And all of this is part of the culture, part and parcel of everything I was saying up to this point, and a safety culture which then values bad experiences, adverse experiences, just as much as it values positive experiences. You never want adverse experiences to happen, but they inevitably will. You need to value both of those when they happen as the basis from which learning can occur. So here are some examples of what a learning health system will routinely enable. Remember, a learning health system is one where the continuous process of study and learning and improvement is going on in a way that is integrated into the fabric of the environment. So one of the enablements of a learning health system is the continuous pursuit of best and safer care at lower cost. And this happens in a learning health system through the formation of communities of interest who come together to create what I'm going to call in a minute virtuous cycles of study, learning, and improvement. And the meeting is kind of structured today around this concept. If we think about what the groups are going to do later today, each one of these can be seen as the seed of a virtuous cycle of a community of interest that will come together around their interest in addressing a problem and creating what we're going to call virtuous cycles to generate learning and improvement in that area. Another important enablement of a learning health system is enhanced public health. And one example of this, and it goes a little bit to the surveillance example I showed earlier, is that we will be able to track epidemics almost in real time, and because we know where the disease is, we'll be able to predict where it's going, and we'll be able to warn clinicians, alert clinicians, who are in the path of the epidemic that the disease is in fact coming, and be on the lookout for this symptom complex so you diagnose it accurately and not confuse it with one of the diseases that the epidemic disease might mimic. And then consumer empowerment, extremely important. In a learning health system, patients facing difficult decisions will be able to ask and get an answer to the question, what happened to patients like me? Not patients who were in a clinical trial done 5 years ago, but patients like me who chose treatment option A versus treatment option B. People are facing life and death decisions about themselves. These decisions are critically important to them, to their families, and they will have the information they need to help them make better decisions. So how do we learn in a learning health system? We learn through establishing virtuous cycles around a problem of interest, around problems of interest. So a learning process starts when a community of interest comes together to address whatever problem it is that has attracted their attention, and you can think of that as an on-ramp down at 6 o'clock onto this cycle. And once the community of interest comes together, they assemble, they decide what data they want to assemble about what is happening now. And I'll give you an example of this in a minute. They then, coming around to 10 o'clock, analyze these data, and that allows them to determine what practices are associated with better outcomes. Those results, after they are interpreted, are fed back in a customized way to decision makers. The decision makers might be patients, they might be providers, they might be organizations. This is what you're doing. This is what has been shown in this first cycle of study to be associated with better outcomes. So in your particular case, these are the changes that would be recommended for you. This is the delta between what you're currently doing and what best practices have been identified. Then the entities participating in this community of interest would take action. They won't do everything necessarily that's recommended, but they will do some of those things. And that will then fuel the next cycle, because this changed behavior as a result of taking action will create new experience data, which will fuel a next cycle of learning by study and analysis and feedback. And through successive cycles, whatever it is that is the problem of interest will improve. So here's an example. And let's assume the problem of interest is the widely acknowledged problem of reducing falls in nursing homes. The process begins with the decision to study falls. A community of interest would come together to do that. Then they would assemble data, and the data would be, how do we prevent falls now in the nursing homes that are participating in this community of interest, and what is their experience as a function of that? Then the analysis would associate specific practices with lower fall rates. There would be an interpretation of the results by the members of the community of interest. Feedback would be customized to the nursing home, saying, based on what you do currently, you might want to consider changing the following things to align with what we learned. And then the nursing homes participating in this community of interest would take action, choosing to change their current practices in whole or part. And then those actions would engender change, which would generate the next cycle. Now, this slide's a little bit abstract, but it goes to the key point about the learning health system and making learning routine. In a learning health system, in order to learn efficiently, what you want to do is put in place a platform, seen in this ring on the bottom of this diagram, that sits underneath and supports large numbers of virtuous cycles each addressing a different problem and may be cycling at a different pace simultaneously. So the learning health system is an infrastructure that, in our case, we're talking about extending across the entire state that would support multiple virtuous cycles going on simultaneously across the state, addressing many different problems. What problems will get addressed? The problems that will get addressed are the problems around which communities of interest form. There are no preordained in a learning health system problems that get addressed. So let's think about a simple analogy to illustrate why this concept of a single platform underlying a large-scale, in this case statewide, learning health system might be an appealing concept. We've all been in this situation. Suddenly we need to do a large amount of wash in one day. And it's more than we can possibly do in our own washing machine at home. So you got a choice, right? You can find, if you have 20 loads of wash to do in one day, you can find 20 neighbors, negotiate to use their washing machines, find out when they're not going to be using their washing machines, find out what kind of detergent their washing machines use, and you can go around to 20 houses and get your wash done that way. Not very efficient. You might get there, but not very efficient. Or you can go to a laundromat. Take all your wash to one place, put it in the machines, put your coins in the machines, and get your wash done. And moreover, you'll be confident at the outset that your wash will get done because you know the laundromat is there. It's a persistent infrastructure for getting your wash done if you have a lot of wash to do in one day. And if you think about it, the laundromat is like the platform that the learning health system would create, because the learning health system is what enables these multiple virtuous cycles to be going on simultaneously and efficiently. Without a platform, and this is the situation we're in now, we do lots of studies. And I'm not saying here to you today that we are not studying what we're doing, we're not learning and improving. What I am saying, we're not doing it efficiently and routinely. Almost every study we do is a one-off. It requires its own agreements, its own technology, its own staffing, analytics, dissemination techniques. That's why clinical research costs $50,000 per patient. There is no economy of scale. And if we tried to build a learning health system that way, the 10th virtuous cycle we implement would cost the same amount as the first one. But with a platform, all of these cycles are floated by this infrastructure. And you can think about what we're here today is to start thinking about how we might evolve a statewide infrastructure. And if you have this infrastructure, if you have this platform, then there is economy of scale. And the 10th cycle that you implement costs a small fraction because it inherits all the technology, the agreements, the staffing, and the analytics that you created to do the first one. So if we're living in a learning health system, as I said, there are many virtuous cycles going on concurrently. Study and continuous improvement are a norm. We're on that learning curve that Tom was talking about. As you saw and probably inferred from my example, current best practices are being routinely fed back to stakeholders and decision makers so they can implement them. And there are two anthems that folks who advocate the learning health system use, and I think it's appropriate to introduce them at this time. We can learn from every patient, and we can reduce that gap between the discovery of what constitutes best practice and its actual implementation from 17 years to 17 months to 17 weeks, and maybe in the case of a public health emergency where literally days and hours mean many, many lives, to 17 days or 17 hours. So what we're about here today is to conceive of a platform for Michigan. If you think about, in looking at the upper right of that slide, the ring, which is the platform supporting multiple virtuous cycles, you can think about what that ring might look like in more detail by looking at the rest of the slide and seeing that a Michigan platform for a learning health system would need to have many features to it. It would have to be multi-stakeholder. It would have to extend across the whole state. it would have to be very likely decentralized, meaning that we're not talking about all of the data going into one big database that sits in one place. That's why I use the cloud to depict what's going on in the middle. It will need to have governance, so it is orderly and sustainable. It will need to engage patients. Everybody will need to trust it. All stakeholders will need to trust it. And as I was saying earlier, it will need to be able to support multiple virtuous cycles. The last thing I would point out about a platform that, at least as I envision it, is that it will have reciprocal operation. Every stakeholder that is part of this will put something in and they will get something out. Not all stakeholders will put the same thing in, and not all stakeholders will want to get the same thing out. But the value proposition here, and I think it's a viable value proposition, is that a sustainable and successful learning health system will result in the stakeholders getting greater value out than they put in. So why can we do this now? Why are we talking about this now? Well, we're talking about this now because a great deal of progress is being made along a number of fronts, and I'm going to go very quickly through what some of these are. First and foremost, I think you all recognize from the things I said and some of the descriptions of how the learning health system would work, that a efficient learning health system, a platform, this economy of scale I was talking about, relies on data being available in digital form. And we don't have a completely digital health system yet in this country, but I think it's clear from this graph that we are getting there. And if you just simply extrapolate that green line, which is the fraction of office-based physicians in the country who have a basic but fairly sophisticated electronic health record system in their offices, we're about 50% now. And most experts agree that that slope will at least remain constant, which means we're essentially going to have 100% digital office-based medical practice in this country by the end of this decade. A number of what are called learning islands have formed around the country. These are organizations that within their own boundaries have become learning systems. They are not at the scale of the state. These are entities that have not, as learning systems, routinely learned to communicate with other learning systems, but within their own boundaries they are learning systems. Intermountain Healthcare in Utah is an excellent example of this. Kaiser Permanente is probably the best example of this. And in fact, it was Kaiser that was able to do the studies because of its ability to put its data to work and learn from it that were seminal to the decision to take Vioxx off of the market. The VA, for all of the criticism it has received lately, has achieved the status of a learning island and has dramatically, over the past 20 years, by putting its data to work in learning cycles, improved the quality of care that it has provided. There are also, and this perhaps is even more important, interorganizational federations and networks coming together, and only some of them are being seen here. These are learning islands of a sort because their boundaries are closed and restricted to their members. But each of these networks consists of different organizations that have come together. Some of them are organizations that compete with each other, but they have realized that it is for the greater good for them to come together and share their data to enable learning and improvement around certain problems in which they share an interest. So progress is being made in various ways toward a learning health system, and we are part of a movement here in what we are doing today. There is also a growing grassroots movement called the National Learning Health Community, which resulted from a meeting very much like this one, but a national meeting that took place in Washington in 2012. And that meeting resulted in the expression of 10 consensus core values that underlie the operation of a learning health system. All of those core values are reflected in the things I just told you. many of the organizations that participated in the summit and some that didn't have now formally endorsed these core values. 62 organizations, we have one more since the slide was made, and I think you see many organizations whose names you recognize here, including, by the way, the state of Minnesota. If we want to get inspired by competition here today, the state of Minnesota has set as a formal goal to become a learning health state, and they are embarked on the same journey on which we are embarked. I like to think we will get there first. So that brings my remarks to a close. Just to summarize, what I think we're all about today is to envision how we might work together, bringing multiple stakeholders together around this concept of learning as a higher purpose, to develop something that might or might not look like this diagram, but this is a guess at what it might look like. And today we have multiple stakeholders participating in this meeting as a way to seed this process, and we are envisioning the establishment of early virtuous cycles around problems of interest. And as Marianne is going to describe in a moment, the logic of the meeting and the rest of what is going to happen today is to see if we can move toward action-oriented communities of interest that will really be the starting point for building a learning health system for our state. Thank you very much.
Thank you, Chuck and Tom. I think that was a great introduction to what the learning health state could look like. And we do have a few minutes for questions, and so I'd like to invite you to raise your hand, to ask questions, because we really want you to understand the fundamentals here. What is this really all about? But while you're thinking about that, I just wanted to add something to what Chuck had to say, because I think it is easy to see the learning health state in the context of medical care, to some degree in the context of public health. And I just want to make sure that we all understand the breadth excuse me, of this context. We are really here talking about issues that go far beyond medical care. So think about it this way from a health plan standpoint or from a provider standpoint. Think about the formulary. This is my favorite topic. How many health plans collaborate today on a single formulary? Thank you, Tom. How many times do you as a consumer go to your doctor and they have to look up what formulary you have and figure it out? That does not lead to good medical care. That is not efficient medical care. That is what a learning health state could change. It's not one of the 6 themes we have up there, but it could be. And remember that what we're talking about today is the beginning of a movement. It is not intended to be the be-all, end-all. It is intended to create a structure where we can tackle problems like that together, where we can advance the efficiency of our system so it's adding value, not just adding complexity. Another example, and a more immediate one perhaps for many of you in this room, and that is the Michigan Primary Care Transformation Project. Diane Marriott's here. I know several of you here who participate in that project are all working on care management and how to strengthen care management in practices to make it more efficient and more effective, to deal better with chronic disease. But even though in that project people are coming together to talk about best practices, could we structure something that goes far beyond that for the state to really talk together about how to improve the quality of chronic care delivery in our state? So that's kind of the concept here. Goes far beyond the issue of pure medical care that you can, I think, understand and envision. It really is inclusive of how we deliver health, public health, and medical care all together in the state. And you're going to hear more examples by the panel in a moment. As I said earlier, we are going to ask people to sign up for one of the 6 themes to talk about for this afternoon. The panel is going to describe what those 6 themes are. But if you have passion around another issue that is not up there on the panel, we will have an opportunity for you to create a table to talk about that issue. So you can tell Babette, who's right here. If you have another issue that you want to have a table about, tell her at the break, and we will create another board and people can sign up for that table as well. So with that, I want to see if there are questions or comments about this concept, and I would invite the other planning group members too to comment on it. Peter, you have a question?
Yeah, so what, either Chuck or Tom, what do you think is currently the biggest impediment to a learning healthcare environment in the state?
You want to start? Biggest, so the question, just for those who didn't hear it, is what is the biggest impediment that we think there is to a learning health state? And I'm going to ask each of them to comment.
My answer would be that as health professionals, we have been imbued with a culture that says as long as we possess the knowledge, attitudes, and skills to be a really proficient individual practitioner, we've got it all. When the literature suggests that even really fine, dedicated, knowledgeable practitioners working in a broken system deliver care that very frequently brings harm to patients. We have, I think, tried to learn process improvement, but the process improvement that was really very successful in industry with the Deming and the Lean and the Six Sigma was in a language that we couldn't connect with very well. And after several decades of really trying, it hasn't gotten the traction that we need. So I believe the biggest barrier is that healthcare professionals and healthcare organizations need to look at that same reality of process improvement in a way that really connects and resonates with us as healthcare organizations. And I think that the way that happens is going to be through learning rather than the language of Six Sigma and process improvement. It just doesn't connect with us. So we need to do this. The biggest challenge, I think, is to realize that healthcare organizations need to get on this continuous improvement, but need to do it in a way that really can connect with what they see themselves doing every day, is speaking in a language that they understand and are fluent in, and excites them in what they view their contribution that they're making every day.
And I will be very brief because Tom effectively gave the answer that I was going to give. It's very much about culture. And just to elaborate on one thing, in one way on what he said, I think the way you change culture is by bringing together people who come together and do something in the world that demonstrates success. So I think we can change the culture by illustrating what's possible and set in motion a chain of positive events.
So just one comment. I think the other issue here is that the health science education programs essentially are not creating a curriculum for learning in a healthcare environment.
So Peter, why don't you tell people who you are too? So
Well,
I should have asked you.
I'm covering dean of the School of Dentistry at the University of Michigan. And I've really begun to explore this for the past year because I'm trying to understand how do you get an educational program that is very silent to really think very differently about how to educate these future practitioners. And right now, I think this is a wonderful idea, and I think we have to do this. But there's a disconnect between what's going to be talked about today and what's happening in our classrooms, in our clinics.
Yes, amen to that.
Fran does too. I just want to say one thing though, in addition to this, because I think something to be realistic is that competition is also an impediment to a learning health state because, and we're going to say this, Fran, because, you know, formularies, people are competing on formularies. You want to add to that, Fran? So, say who you are. So.
When we were talking about the virtual cycle, for me, and being my age and years in industry, to me it's been the vicious cycle. And what I want to know is what changes it from a vicious to virtuous. And when you do the Deming PDCA, out what's different about what we're getting from you today.
That's great. Did you hear that in the back? Dennis, did you hear that, what Fran had to say? So the vicious cycle, how do we get to the virtuous cycle from the vicious cycle?
Ask Fran what.
You asked Fran.
You were the microphone. Fran, what makes a vicious cycle as opposed to a virtuous cycle?
Not getting to a measurable result, not getting to me to continue to study and not act. And so, like one of the things we're talking about is immunization rates. I probably, if there's been 1,000 panels on improving immunization rates. What in the learning cycle is going to make those immunization rates actually go up? Also, for me, it's we have a plan of learning, and people that are learning, when I look at it, they can learn from each other, they can learn from teams. You emulate people that are doing it well, you franchise them, you remediate the ones that aren't. We don't start with people that don't learn them. And so what I want to know, those are things to me that are impediments. So.
Yeah. Do you want to comment?
Tom,
Comment. Oh, you both want to comment. That's good.
I think the first thing that creates a vicious cycle is just not having the information that you need to discover the impact of the changes that you've put in place, so that you can then learn in a timely enough way, so that we're operating in a vacuum. And one of the things that we have with these collaborative quality improvement initiatives across the state that Chip Campbell organizes in many cases is that people are given the support to get the data that they need to know whether or not people after their surgeries have had to go to the emergency room, have had an infection, and the data that says what those different centers do differently, so that you can understand the different outcomes that they're experiencing. And that data support has not been present. It's not paid for in a fee-for-service system, because the fee-for-service system will give you the same fee whether you did any of that or not. And so I believe that a lot of it is getting the information that you need, and it's usually clinical information and local information rather than claims-based or distant. Getting the support in order to do that, I think, is what most teams fail on. I don't think it's, you do have to develop trust, and at the beginning that isn't there, but that comes along after you work with the information. So that would be my answer to your question.
And I have a complimentary answer to that, but I should say first that Tom, I almost wore that suit today, which would have made for a very interesting session this morning. But I think my point would be that the creators of virtuous cycles, or those who would hope to create virtuous cycles up till now, have not placed enough emphasis on the challenges. If you look in the upper right of my diagram, of the red side, the feedback side, and they've kind of deluded themselves into thinking that if we collect data and we convert it into knowledge and advice, then something magical will happen. But in fact, just as much attention needs to be paid to the feedback side as it does to the collection and analysis side. In fact, a lot of the work that since I have gotten to Michigan, I have been leading there has been R&D to make that right side, that red side, as robust as the blue side, to balance this out and be sure we have complete virtuous cycles. I think they are vicious cycles because the circle is not completed.
Thank you. And you're going to hear about the immunization from Jim specifically. Oh, from Barbara. That's right. Barbara's going to do immunization. You're going to hear specifically about what we think the Learning Health State can do for that. Yes.
Madam Wayne County, my question is for you. What constitutes the platform? And maybe I was thrown by the cloud. Is it more the exchange of data, as Maureen has been talking about the HIE, or is it more integration of the system or systems?
Thank you. Great question, and the short answer is all of the above. The best examples I have of what a platform will look like, again, the proof that it can be done is that it's being done, goes to how these interorganizational networks that exist are currently operating. And they are working, obviously, using sophisticated technology that allows these data federations to share their data without any data actually having to move. There's a technology in place called PopMedNet that was developed at Harvard. It's open source and widely disseminable, that creates the technological platform. And you need technology that works. Technology is only part of a learning health system, but you can't do without it. And this technology does enable members of a federation, of a network, to conduct sophisticated analyses of data, using data around problems of interest. Going back to my previous statement, what PopMedNet lacks is a sophisticated red side. But the platforms to support the blue side, the technologies that are required exist. And if you look at the networks that are functioning, there's a whole policy and agreement and governance component of this. Every one of those networks that I illustrated on that slide is doing it a little bit differently, but they have figured out a way to do it, to develop policies and governance that allow their networks to work, and these have been stable, ongoing activities now for several years. So the platform is a combination of policy and technology, and there are examples of all of that working in the world.
And just to, I think, add to that a little bit, it's not just HIE. HIE is one piece and is very fundamental to some of these components. The technology also helps understand and communicate about root cause analysis, which is not always HIE necessary, but data is necessary, information is necessary, understanding why we have low immunization rates in certain areas for certain things is fundamental. That does not necessarily need an HIE to do that analysis, but we do need data and we do need technology to help this federation to actually figure out what's going on and create the right solutions to that problem. So, and you know, what you're going to see a little bit later is our goal here is to create these communities, these federations across our state who will be working together generally remotely, not coming together in the same room, analyzing the problem, analyzing the data in real time, and trying to figure out solutions and disseminate that across the state. That is what we're trying to accomplish here, and with some, select themes to make sure we can actually do it. So that's where we're headed. Yeah.
I'm Cynthia Green-Evers from the Department of Community Health. What is the minimum information or stakeholder participation that's required in order to have an effective health system?
I think it's partly the answer, or the question was, in case you didn't hear, was what is sort of the critical mass that you need to have one of these federations in place? And I think it is problem specific. Often you have a core group of people who then expand from that core once they've figured out how to really create that foundation, which I think is still an open question. We have a mechanism of doing that for these collaborative quality initiatives that I gave one slide showing the comments of that with joint replacement. I think we know how to do it when we're talking about surgical procedures across the state. I don't think we know how to do it when we find out what the array of problems are that are going to come from the group, and we're just going to have to go through a learning process of deciding what is the critical mass, what are the key elements for success, and then allow them to expand and replicate.
We really didn't rehearse this, but again, I'll just elaborate on an answer that I fundamentally agree with. Each community of interest needs to size itself to the problem it is exploring. And a key element of understanding what is the minimum size for a given community of interest to get a cycle around the problem started is enough size to generate enough variance in practice. because if you have too confined a community that does too many things too much the same way, you can't learn from that. You need different practice so you can associate different practice with different outcomes, and then you can learn. So there are a lot of criteria that go into sizing a community of interest, but you certainly want a community of interest to be large enough to capture the variability from which you can learn and everybody in the community can benefit.
Marcia, sorry, I come over here after.
I'm Marcia Manning from the University of Michigan Benefits Office. I'm a recovering benefits professional from So I understand the value of enriching the learning cycle with more robust data. But my question is really around the feedback about existing quality improvement schemes like Lean and Six Sigma, not necessarily being a fit for the healthcare space. Because there's many large healthcare systems across the United States who have really embraced this approach and been very successful. So are we potentially creating something that's redundant that just has different language in order to get healthcare cultures to connect to it? Because certainly lean, resistance to lean and other techniques may be related to difficulty culture change or whatever the case may be. But I just, it feels redundant to create a new system when we've seen lean and Six Sigma and others work very effectively in healthcare in other parts of the country.
Well, I couldn't agree more with you. Lean and Six Sigma and continuous quality improvement or total quality management are all wonderful ways to improve processes, and there is an element of what we're doing today that is old wine in new bottles. I don't mean to diss in any way those things, and I'm a big enthusiast of them, but I believe that while there are individual organizational stories of success, the larger story is one of unattained opportunity. You know, we haven't captured all the value or a significant amount of it, and I believe that taking the same essential concepts and making them more relevant and successful in healthcare environments across individual organizations through collaborative sort of statewide efforts is a little bit of a new thing, as well as building on the strengths of the old. But I really want to emphasize, I didn't mean to imply that I in any way would criticize those other things, because the concepts that are found within them are extremely valuable, and many of them will be well served in this new foundation.
So adding to that, and thank you for that great point, I actually had a conversation last week with Jack Billy, who's a very prominent proponent of Lean and I guess the leader of UMHS's Lean effort. And we talked about exactly the point you raised. And we saw many philosophical premises in common between Lean and the learning health system, but we saw some fundamental differences. And I think two features of what we're talking about today are important to point out, because I don't think they're intrinsic to Lean. Or one of them is more of a contrast. Lean, as I understand it, is very dependent on what might be called small data. One person studying his or her job, doing an experiment, a small-scale experiment, and figuring out how to improve their own work environment. Whereas the learning health system is complementary to that by focusing on what the overused term big data. How can we pool large amounts and routinely study large amounts of data about our practice? So in that sense, I think the two are very complementary. Another point about that came out of my conversation is that Lean doesn't really have the very well developed right side, red side, and I asked Jack if one employee here learns something about her job that is relevant to what an employee over here needs to know about his job, how does that happen? And I think he said, and I'm not an expert on Lean, but I'll go by what Jack said. He said this is a challenge for Lean right now. He said some organizations develop what's called the book of knowledge, and the learning goes into that book, but that's almost like what we have now in our non-learning health system that leads to the 17-year gap, because the knowledge is entombed in journals where it sits for years before it is widely uptaken. So I would just suggest those are two areas, recognizing a philosophical harmony here where the learning health system and lean differ from one another, but I think they can synergize. I think by using both approaches we can get to the goals we all share even faster.
Yeah, go ahead.
Kathy Bosney from Governmental. Curious about linkages between this anticipated approach and the state's innovation model. If there is any work going on in that space already, or do you see this as an enabler or a complement to that? The second question is really about macro funding. Does each virtuous cycle group need to come up with their own system infrastructure funding, or is there some master plan which puts in place a framework that allows virtuous cycles to come together and utilize it?
Yeah. Excellent questions, both excellent questions. One about the SIM grant and how does this fit with that, and the other about resources and funding. I'm going to ask Tom to start a bit on the SIM grant, though we have many people from the Department of Community Health here who could speak to that too. And then I'm going to ask Chuck to talk about the resource issues. So, want to talk about SIM?
First of all, your question about is there sort of a master plan that we're working from, and the answer is no. This is really starting at the beginning and seeing how we can take it and learning what we need to develop. I do believe that as most of the health systems realize that their contract environment under which they work changes from fee-for-service to basically population management-based compensation, that there's a whole new set of problems to solve, and that resources must be applied to solve those problems. And all of the resources originate with the customer, like Dow. They then often funnel through health plans and get to providers. All the money comes from the customer, and I think that that's going to continue. And I think that the important thing is we have to use that money in a very responsible way, and we have to figure out how to channel it effectively so that these things don't become vicious cycles because they're so starved of the resources they need to succeed. And so I don't know how to answer the question, but I do think it's the right question to ask.
Gee, these are terrific questions you're all asking, and thank you for that. I'll address the second question you asked. So here's the method here. We're going to talk about 6 or maybe more problems of interest. And after this meeting, we will, we're going to talk about 6 problems of interest. If this effort succeeds, quote unquote, by spawning 6 productive virtuous cycles, but with each one having its own infrastructure, rules of engagement, so on and so forth, we've succeeded, but we've failed. We've created 6 virtuous cycles, but we failed to create a learning health system. Or we've created 6 learning health systems that don't talk, 6 smaller scale learning health systems that don't talk to each other. So I'm not sure yet exactly how we're going to do this, but if we come out of this meeting with interest groups around a set of virtuous cycles, we are going to also need to have some sort of cross-cutting group that is going to look for opportunities and must succeed in finding them to create common elements supporting the commonalities of these virtuous cycles so that we evolve toward one platform and not 6 of them, which, like I said, if we do that, we've succeeded, but we failed.
So let me say a word about the resource question, which is very key. In your sessions this afternoon, you're going to talk about what resources would be needed to take this particular theme forward. We do not have a pot of money here that could be necessarily dedicated to this effort. We do want, and we will look for funding to create what Chuck just described, the overall infrastructure that can pull this together and to help advance these 6 initiatives. But the initiatives themselves, we're going to have to look within each of those groups to say, in some cases there are resources already available. In some cases there are many groups already working on these issues in the state, and the key is to actually bring them together. In some cases, it probably is new resources that are needed, and that's what we need to know from the tables this afternoon. In this concept of the SIM grant, the SIM grant will, in fact, we hope Michigan's going to be successful in getting the federal government to support our SIM grant. There will be some resources that come to the state, we hope, from that grant. And the concepts in the SIM grant are very aligned with what we're talking about here. So if you think about it this way, and we kind of put this into our vision statement in terms of, the state that created the automobile could be the state that creates the learning health state. We're trying to create a structure that can be applied to any problem in the state in the healthcare and health space, right? And we're starting with, you have to start with something concrete to get there. And so we're starting with some ideas of things where we could actually try this and then create the structure with that. But in the end, the goal is to have something in place that could be employed to get to the goals that are in the SIM grant, that could be employed to get to the goals that folks identify in the public health department for a variety of things. So that's really where we're headed here. SIM grant's not technically part of this initiative, but what we're creating will advance the work of the SIM grant. That's great. One more question?
I just want to verify, in these sessions, are we going to talk about what we actually need or what that infrastructure needs to be?
So in the sessions, well, I'll give you the charge in a little bit, and your theme leader will guide you through the session, but the focus is really going to be on that theme. We'll talk about the planning group and others, and let us know if you want to be part of the thinking about how to create that overarching infrastructure, which we'll create after the session when we see where we end up. So the groups are going to talk about the themes and what those themes need to go forward. Then we will separately talk about that overarching infrastructure and how can we advance this work.